Hello everyone, and welcome to the second session in Chapter 15, titled History Taking. As always, this is Keith Whitmire with Wayne County EMS. Let's go ahead and get started here. We're going to get started with one of our very basic mnemonics. This is one thing that you should be utilizing during every run. This mnemonic is referred to as the OPQRSTs. You will hear this time in and time out. On every run, if you look at the K-Beam skill sheets, you'll see that they actually refer to the OPQRSTs in their history taking. This goes under the S part for the sample history, which we'll get to here in a moment. If your patient is complaining of pain, OPQRST is the memory aid, the mnemonic, that may help identify the type and location of the patient's complaint. We're going to start off with O, onset. When you're talking about onset, you're going to ask, what were you doing when the problem started? Were they sitting on the couch watching TV? Were they mowing the lawn? Were they running a marathon? Then we're going to talk about provocation. Provocation, what makes the problem better or worse? If you wanted to discuss palliation, you could say, in what position was the patient found, and what should the patient remain in that position? But the big thing I want you to remember when we're talking about P is provocation. What makes it worse? Quality. What does the pain feel like? Is this dull, burning, sharp stabbing, shooting, throbbing, pressure, or tearing? It's very important to keep in mind, you don't want to lead your patient. You don't want to say, is this a burning pain? Because your patient will be like, oh yeah, it burns, it's a horrible burning pain. Or, is this a dull pain? Ask them to describe the pain. That's a much better way as opposed to leading them, because you may not get the responses that you're looking for, or that fit the complaint. Radiation. I know in the book it talks about region as well, but radiation is the R that I would really like you to utilize. Where's the pain, and is the pain in one area, or does it move? Is the pain located in any other areas? In EMS, when we're assessing a patient, we often have what's known as referred pain. So, for example, if you are evaluating a patient with chest pain, they may have mid-sternal chest pain, and it may be radiating down one or both arms, and it may also be in the jaw. Well, the chest, the heart, and the jaw have very little to do with each other. But because of neuroreceptors and referred pain, the pain gets referred to different parts of the body. And by knowing which referred pain corresponds to what type of injury, this will help you evaluate your patient and appropriately treat them. Next, we have severity. On a scale of 1 to 10, 1 being virtually no pain, and 10 being the worst pain you've ever experienced, what number would you assign to the pain or discomfort that you're experiencing? Remember, this is relative. What I consider to be, a 6, you may have Adam may consider it to be a 4, Joshua may consider it to be a 10. So this is all relative to that person. And then time. Time is how long ago did the problem or discomfort begin, and have you had this pain before? When? How long did it last? How long have these events been lasting? When you're caring for patients, a yes pertaining to an illness or injury is considered a pertinent positive or positive finding. A no is considered a pertinent negative or negative finding. For example, when you're caring for a patient who has asthma, pertinent positive findings would include shortness of breath and/or a feeling of tightness in the throat or chest. Pertinent negative findings would include no history of recent cold, bronchitis, pneumonia, or other infection. When you're caring for a female patient who is complaining of abdominal pain, pertinent positive findings include a sexually active woman whose last menstrual period was 6 weeks ago. Partly negative findings include no recent abdominal trauma or illness, and no recent history of abdominal surgery or vaginal infection. Another important part of the history-taking process is the relevant family history. Ask the patient about related problems of family members. For example, if the patient is complaining of difficulty breathing and has a history of asthma, ask if there is a family history of asthma. If the patient is complaining of chest pain, ask if there is a family history of heart disease. Document the family member's relationship to the patient so that this information can be relayed to the receiving facility. Ask the patient about conditions that they may have that may help you determine what the problem is today. If time permits, ask about childhood illnesses and immunizations, adult illnesses, accidents and injuries, physical disability due to previous illness or injuries, recent hospitalizations, or surgical procedures. If the patient is unresponsive or has an altered mental status, look for a medical identification tag, look for medication patches, look for surgical scars. Allergies are common and may be the reason why you were called to the scene. Find out if the patient has an allergy to medications, food, environmental causes such as pollen or bees, and products such as latex. Ask the patient or bystanders if the patient is unresponsive. Do you have any allergies to medications? Are you allergic to latex? Do you have any food allergies or allergies to insect stings, pollens, dust, or grass? Check for medical identification tags. The patient may be wearing a bracelet or a necklace or carrying a wallet card that identifies a serious medical condition, allergies, or medications that they're taking. Find out if the patient is currently taking any medications. You'll need to ask specific questions because some patients do not consider some substances medications, such as vitamins or aspirin. Examples of questions to ask include, do you take any prescription medications? Is medication prescribed for you? What is the medication for? When did you last take it? Are you taking medication for birth control, pills or injections? Do you take medications for erectile dysfunction? Do you take any over-the-counter medications such as aspirin, allergy medications, cough syrup, or vitamins? Do you take any herbal medications? Have you recently started taking any new medications? Have you recently stopped taking any medications? Do you use any recreational substances such as cocaine, marijuana, or alcohol? Remember to ensure the patient understands that you're not the police, you're not there to arrest them, you're there to take care of them. This will hopefully allow them the opportunity to open up to you. Make sure that you talk to them about the different medications that they may be on and whether or not those medications are prescribed to them. Particularly in older populations, you may notice some groups getting together and exchanging medications, maybe from spouses who've passed away or from themselves if they've been switched to medications. And these patients may not understand that Johnny's blood pressure medication is not the same as Susie's blood pressure medication, which is not the same as Randy's blood pressure medication. They may say, well, if you're having blood pressure problems, here you go. This way you don't need to go and buy your own medications. And this can become a very, very big problem. You'll see this in communities. Sometimes I've seen it in the past in urban areas where geriatric populations get together in church groups and pass around medications. And they believe that they're helping each other out when in fact this can become very, very harmful. Ask the patient about personal habits. Ask the patient about tobacco use, what type, cigarette, cigar, pipe, or chewing tobacco, and the years of use. If not already done, ask about the use of alcohol, including type, beer, wine, or hard liquor, and the number of bottles, glasses per day. Ask about the frequency of use of coffee, cola, and tea, and the number of cups or ounces per day. If not already done, ask about the use of recreational drugs. In some situations, ask about the patient's diet. For example, if the patient has diabetes or appears malnourished, it will be essential for you to ask about the number of meals or snacks the patient consumes per day. It is also important to determine when the patient last ate or had anything to do with drink. This is especially important if the patient is a diabetic or may need immediate surgery. Determine what the last thing that they ate or drank was, and how much they ate or drank, and when. Sorry about that. I skipped ahead on the slides there. Give you guys a second to catch up. Alright, we're going to go ahead to the next segment here. The next mnemonic. This is the last mnemonic for this section. This is entitled Sample History. In EMS, sample is a memory aid used to standardize the approach of history taking. VS stands for signs and symptoms. A stands for allergies. M stands for medications. P stands for pertinent past medical history. L stands for last oral intake, and E stands for the events leading to the injury or illness. Medications will help determine what the patient's medical history includes. Pertinent past medical history is important because it's not really pertinent for a current chest pain issue if somebody had their appendix removed 20 years ago. Last oral intake may help assess the signs and symptoms of what's going on. This is the end of Chapter 15, Therapeutic Communications and History Taking.